Rheumatoid arthritis is an autoimmune disorder where the inflammatory cells attack the joint as well as can attack other organs. It's primarily a musculoskeletal disease, but it's associated with systemic features such as fatigue, possibly low-grade fever, weight loss, and so forth. And what we know from a great deal of basic and clinical research is that there is an inflammation of the lining of the joints. The synovium becomes inflamed. The synovium is a membrane which lubricates the joints, generally a fatty tissue, small blood vessels. But with rheumatoid arthritis, it's almost like a tumorous overgrowth. You get neovascularization, new blood vessels, and you're chock full of cells, activated T cells, B cells, macrophages, which produce inflammatory peptides, which also stimulate the growth of the synovium so it proliferates and eats into the cartilage and eats into the bone. And we know that synovial osteoclasts are what cause the erosions and structural damage that occurs with rheumatoid arthritis. So in summary, it's an autoimmune disease with multiple arms of the immune system upregulated. We don't know, unfortunately, even after all these years, what's the trigger for the disease. We know there's a genetic background, the DR4 locus, which plays a role in seropositive rheumatoid arthritis, but we don't know what actually triggers the disease. If a patient presents with inflammatory arthritis, we need to evaluate them to see if they have rheumatoid arthritis or one of several other forms of inflammatory arthritis, such as psoriatic arthritis, lupus, or non-inflammatory arthritis, such as osteoarthritis. Rheumatoid arthritis classically is a symmetrical polyarthritis that one wrist is involved, the other wrist is involved, one knee, the other knee, although there are plenty of exceptions. The diagnostic workup relies heavily on the history and the physical, like all of internal medicine diseases. And generally we then do laboratory and x-rays sometimes to confirm the diagnosis. So in a rheumatoid arthritis patient, by the time we finish the history and the physical, we would have well been able to discern that they have an inflammatory arthritis. And then we need to try to figure out what type of inflammatory arthritis they have. So we will check laboratory to include a rheumatoid factor and citrullinated peptide antibodies, CCP antibodies, along with acute phase reactants such as sedierates and CRPs. And if these are abnormal or positive, then we can make a diagnosis. We have several features that allow us to differentiate between low and high-risk patients. A high-risk patient is someone who has CCP antibody positivity and to a lesser degree rheumatoid factor positivity. They are at greater risk of disease progression, structural damage, non-musculoskeletal manifestations of the disease, whether that be what we used to see, like pericarditis, pleurisy, things of that nature, sensory motor neuropathy. Patients who have elevated SED rates and CRPs, patients who have baseline structural damage on x-rays are at higher risk for disease progression. We also know that factors such as socioeconomic status and education, poor socioeconomic status, the lesser educated patient has a worse prognosis as well. There have been some conflicting results on study on gender, some suggesting men may have a worse prognosis, but that have not been substantiated. So generally, seropositive patients with structural damage are at higher risk, and those are patients who should be treated aggressively from the onset.